Alright, let's continue with some more information about the auscultation of the heart. All that information about splitting, whether it's a wide split or paradoxical split, really isn't helpful without considering the context of actually auscultating the heart. On my Step 1 exam, I had multiple questions with a digital scope that presented an interactive patient within a vignette. I could hear the heart sounds depending where I placed the mouse or the digital stethoscope. I did not have any practice questions like this at all. Of course, I had a sudden rush of panic and anxiety when I realized how the question was set up, but I thought back to the fundamentals that I'm about to present to you here, and I figured out the answer without even reading the vignette, which I don't recommend at all, but I was on a time crunch. This is not only important for your exam, but knowing where to listen for certain sounds is an important part of the cardiopulmonary physical exam that you will perform an endless number of times while in clinical rotations in your third year and on. You should understand that the location at which heart sounds or murmurs are best heard does not necessarily correlate where the valves are actually located anatomically. So as you can see, the pulmonary was represented by the P, the A representing the aortic, M representing the mitral, and T representing the tricuspid valve in blue with A lettering is actually where you would see these valves anatomically in relation to the chest wall. As you can see that the other letterings in white attached to the line that describes what area we're listening to is where you actually hear the murmurs best. So why is there a difference between where the valve is actually located and where you actually can auscultate the best to hear a murmur related with a particular valve? So blood is being tossed around all over the place in these chambers, over valves, and unfortunately sometimes the wrong way, in something like mitral regurgitation. Sound is transmitted differently through a fluid and a solid. For example, a lot of the murmurs that occur in association with the left ventricle will usually be best heard at the cardiac apex because this is where the largest ventricular mass is located. Remember, sound waves travel best through solids because all the particles are very condensed and transmit the vibration of particles the fastest. That's all sound is. So it is important to understand that sound is just a mechanical vibration that must travel through a medium, such as a gas, liquid, or solid. If the medium has variable physical properties, such as a gas or fluid, the waves can be refracted and not travel as well. So for example, in a gas or liquid, where the particles are spread out, the sound waves can bounce off these and not travel in a very directional forward movement. As opposed to solid, when the particles are very compact, they will bounce off each other and continue the propagation of sound in a more efficient manner. So guess which medium doesn't refract sound waves as much because all the particles are rather constant in space. Something really solid like that left ventricle, right? So with this in mind, you should ask yourself 4 questions when examining heart sounds or a murmur. Number 1. What sound should I expect to hear in the location I'm in? Number 2. Where does this occur in relation to S1 and S2? Am I in systole or am I in diastole? Number 3. Maneuvers. What maneuvers can I do to make this murmur louder? And number 4. What is going on in the vignette that should make me think about a certain type of murmur, or history in the patient that is already predisposed to a certain type of murmur to begin with? I'm going to combine the information and images regarding auscultation of the heart and cardiac murmurs in your first aid book. It is much easier to consider where you would hear the murmur, what would cause the murmur, and different maneuvers to augment the murmur altogether, instead of separating them into different pages and tables. I'm not going to discuss the chart that shows the bedside maneuvers to augment the sounds individually. Rather, I will incorporate these in the explanation of each individual murmur. Again, I want to help combine things together so that you will understand these instead of requiring to memorize anything. But in general, you can definitely memorize one thing. All right-sided murmurs will increase with inspiration because more blood will flow across the structures on the right side due to the increased compliance of the pulmonary vasculature from the increase of negative intrathoracic pressure, while expiration will cause increased sounds of the left side due to pushing that blood that we accumulated in inspiration in the pulmonary vasculature into the left atrium, into the left ventricle, and across the mitral valve and aortic valve into the aorta. Well, quickly, let's review why does expiration increase sounds on the left? Well, you will be decreasing the recently expanded thoracic cavity from the inspiratory phase, and this causes an increase in intrathoracic pressure. This increase in intrathoracic pressure press down on the vessels. So remember, we are expiring, so we're pushing down the vessels because we're decreasing the negative pressure that we just created during our inspiratory phase. And that will actually compress down on the vessel and make blood rush out. So why am I telling you to approach them by determining if they occur in diastole or systole? Well, it will really help when you're actually auscultating, because you know that systole occurs between S1, which is the closure of the mitral and tricuspid valves, and S2, which is the closure of the aortic and pulmonic valves. So that is your systolic period. Anything after S2 or before S1 is diastole. So what are two murmurs that we need to know about that occur in diastole? We need to think about aortic regurgitation and mitral stenosis. So what is going on with these murmurs? Let's quickly review how blood behaves so we can understand why these pathologies are causing an audible murmur. So remember that blood, and fluids in general, likes laminar flow, like sheets of paper stacked on top of each other, just flowing in the same direction, and the only thing that would be limiting it will be the intrinsic friction of itself. And if you're looking down a vessel to the cross-section, blood flows in little concentric circles, with the center actually having the highest velocity of flow and getting slower as you get closer to the vessel wall. Each of these circles of flow is rubbing against each other with the highest resistance on the outside where the blood is touching the vessel wall, here. The velocity will increase as you go closer and closer to the center of the vessel. I'm sorry to do this to you guys, but this is an incredibly helpful equation to understand why murmurs occur. It was named after some dude named Reynolds. You don't even need to memorize the full equation. Let's just break it down into simple terms that we need to understand. So the equation is Reynolds number equals the radius times velocity divided by viscosity. Turbulent flow will occur if you make the radius really large so that the flow in the middle of the vessel is so fast compared to the flow near the vessel wall that the vectors of flow start looping back on themselves and causing turbulence. So if the vessel is huge and you have flow that's really slow out here, and as you get closer towards the center it starts speeding up, eventually this will get so fast that it can actually drag back on the slower components of the flow vectors, and this can cause turbulence. You can also increase the velocity by decreasing the aperture. So instead of this very large diameter, we can have a very small opening, and for this high level of flow to get across, you have to have very high velocities. And this can actually increase the Reynolds number when we get turbulent flow. How else can we increase Reynolds number to get turbulent flow that will cause a murmur? Well, in the denominator we have viscosity, which is the ability of a fluid to slip and slide against itself. If you decrease the viscosity in a situation like anemia, less hemoglobin will decrease the viscosity of the blood. You're now dividing by a much smaller denominator. Whenever you divide by a very small denominator, you're going to increase whatever you're calculating for, and that will increase Reynolds number. This is how you can get a physiologic murmur with anemia when there's no actual structural damage or dysfunction of any sort of valve or part of the heart. So look in the aortic area and see the second bullet called a flow murmur. This is exactly what we were talking about in the situation of anemia, when you can have such low viscosity that it will drive your Reynolds number up and can eventually cause you to have a murmur that is physiologically due to low viscosity. There's no actual structural problem at all. This is a favorite of question writers, and it actually showed up on my exam. Why do you think that people with no structural valve problems can have a flow murmur? Well, the low hemoglobin decreases the viscosity of the blood so that it flows with a much higher velocity. You better believe that this is a concept that test examiners will come after you with. They love incorporating physics into the cardiology section. With all of this in mind, let's examine the two diastolic murmurs that I want you to know that will help you dominate your Step 1 exam. In the case of aortic regurgitation and mitral stenosis, the laminar flow is interrupted because the diameter of the opening is very small in both situations. This creates turbulent flow because the blood that can flow over that small aperture will be doing so at a super high velocity. In the case of aortic regurgitation, so we have our aorta, and then aortic valve, and then the left ventricle. In the case of aortic regurgitation, the backflow of blood over the incompetent valve leaflets will occur, and that will increase the velocity so high that you hit the threshold in the Reynolds number calculation. And in the situation of mitral stenosis, when you are trying to fill the left ventricle across a stenotic valve that will not open, the calcified mitral valve cannot open for you, so you're trying to dump blood into the left ventricle across a tiny radius, which also causes a larger increase in the flow velocity. In both situations, you cause turbulence and a vortex, like so, where blood is flowing in many different directions. This creates vibrations that can be heard on auscultation. In some situations, these vibrations can become so powerful that you can actually feel them, which you would call what? A thrill. We reviewed some of the physiology, why the murmurs of aortic regurgitation in mitral stenosis occur. Now let's jump into how they sound and some pathologies of each valve that can cause these decreased diameters or radii that create our audible turbulent flow. So at the left sternal border, in the third intercostal space, you would hear aortic regurgitation. So remember, 1, 2, 3. This is our third intercostal space. This is the left sternal border, and this is where you would hear aortic regurgitation. This should make a lot of sense because the flow of blood is across the incompetent aortic valve. It is flowing backwards, instead of where a systolic murmur that you would hear to the right of the atrium, to the right of the sternum, in the second intercostal space where the vector is up and to the right. The flow is backwards, where this flow vector is this way. That is why you can hear the murmur in this location. So what does this sound like? You can hear how this is starting at the onset of the S2 because that is exactly when the aortic and pulmonary valves close. The aortic valve doesn't close properly either because the valves cannot touch due to their bases being pulled too far apart, so we can have aortic root dilatation pulling these valves apart, causing a small aperture where you can have regurgitation. You can also have wear and tear of these valves in the case of a bicuspid aortic valve, or you can have endothelial surfaces destroyed that actually cover the valves due to infection in the case of endocarditis. So you can have little bacteria seed the actual endothelial surface covering these valves. Or you can even have antibodies attack these valves in the case of an autoimmune antibody assault, such as rheumatic fever. This is a great time to flash back to your immunology. What is the protein present in the group A streptococcal species, Strep pyogenes, that our immune system will produce antibodies to that will eventually cross-react with heart antigens? Well, there is actually two. One is M protein. Remember, the M protein shares epitopes with myosin. And I remember this because they both start with N. The antibodies produced against the M protein can actually cross-react with the myosin in the heart. Now, Strep pyogenes also has a polysaccharide component of the group A strep family, and this can cause cross-reactivity with glycosaminoglycans that are present in our connective tissues, particularly covering the heart valves. So it sounds like a really bad idea, right? Our body's making antibodies that can end up binding the myosin of cardiac tissue and glycosaminoglycans that are covering things like our heart valves, right? You better believe it. That is why streptococcal pharyngitis is kind of a big deal when you see it in the pediatric population or whoever has it. You want to jump all over it and make sure you treat it properly. So what else can these antibodies bind? How about a ganglioside in the brain? Of course, ganglioside has components of glycosaminoglycans that share very similar structures. And how do you think this will present when you make an antibody against gangliosides? You will get the famous chorea. Chorea just means dancing. So you get abnormal movements whenever you have the presentation due to the production of antibodies against ganglioside. To include some more review of immunology, let's quickly discuss how this occurs. So let's say someone has group A strep. It is taken up by antigen-presenting cells in the tonsils. They activate CD4 T cells. The CD4 T cells become Th2 helper T cells. They induce the activation of B cells, which become plasma cells. and they start pumping out all this antibody. And due to molecular mimicry, this antibody that's actually against M protein and the polysaccharide component of the group A strep, you can actually have binding to glycosaminoglycans of our body and myosin. Eventually, the deposition of cross-reactive antibodies will cause activation of the complement system on the valves and within the myosin. This recurrent inflammation can lead to fibrosis and thickening of the valve leaflets, and you can even have the edges of the valve start to fuse together. So that is the pathophysiology behind how people get rheumatic fever. Now let's go back to the aortic regurgitation. This murmur is described as a high-pitched, blowing, early, diastolic, decrescendo murmur. Let's just think about what is actually happening in aortic regurgitation. Blood is coming back into the left ventricle during diastole. The murmur is decrescendo because the back pressure is highest at the point where the aorta is recoiling right after the finish of systole that just occurred, and hence blood is being pushed back against the superior surface of the aortic valve. So this is our aortic valve. We just finished systole, so there's a B recoil because this vessel was distended out initially in systole, and now it's going to bounce back. And by bouncing back, it's going to push blood against the superior surface of this aortic valve. And if for any reason there's incompetence of this valve, you can get blood that will leak over. And that is going to be highest at the initial onset of diastole, which is immediately after S2, and it will kind of decrescendo, or decrease in intensity. It will decrease as the aorta returns to its normal distension. So how can we increase the sound? Well, if we make the patient squeeze down and close their hand grip very tightly, we will compress the peripheral resistance arterioles. Just think about how many small arterioles are in your hands. By doing so, we increase the pressure and increase the backflow of blood, and the murmur will also increase because we have increased our afterload. So we have our hand grip, which increases TPR, which means that we increase our afterload, which means that the pressure in the aorta will be high that we're pushing against. So it'll really distend this wall, and the recoil will push back on this incompetent aortic valve. How can we decrease the murmur of aortic regurgitation? Well, we can give someone a vasodilator, such as hydralazine, and that will open up these peripheral resistance arterioles that we just said we can crimp down on with hand grip. So we're doing the exact opposite. So this decreases your TPR, which means we decrease our afterload, and therefore reduce the murmur of aortic regurgitation. Now what about mitral stenosis? That poor old mitral valve got beat up by rheumatic fever back in the day, and now has replaced some of its connective tissue with calcium and fibrotic tissue. Remember, the autoimmune-induced attack to the mitral valve caused necrosis of some of the endothelial cells. So you have your mitral valve, and it's actually covered with endothelial cells. Remember, rheumatic fever, we deposited antibodies on those endothelial cells because we made antibody that was very similar to the glycosaminoglycan component that helps hold some of this connective tissue on the mitral valve. Eventually, we cause necrosis because we activated complement, and then this can lead to dystrophic calcification, which will occur because we expose phospholipids in the damaged cell membrane. Guess what divalent cation loves binding highly negative phosphate groups in those phospholipids that we just exposed? It's right here, calcium. Okay, back to the murmur. Where can you hear it? Remember, the largest mass of the left ventricle is at the cardiac apex. So sound will travel through the largest muscle mass, and that is why you can hear it here in the fifth intercostal space, slightly to the left of the cardiac apex, which is also where the cardiac apex sits very close to the anterior chest wall. Also, think about this is our left atrium, and this is our left ventricle. Think about where that flow murmur vector is occurring. Blood is flowing from here into the left ventricle across this very small opening because our mitral valve is stenotic. This is our mitral valve. The flow vector is towards the cardiac apex as well. And when is this occurring? Probably during diastole, when the mitral valve is trying to open up, but it is struggling because it has gone through some beatings. What do you think happens in the second part of diastole when we have our atrial kick? Well, this left atrium is going to flex real hard, it's going to contract, and push that blood against that stenotic mitral valve. You think that atrium will flex hard enough to push that valve open? Of course it will. This is the opening snap that can sometimes be associated with the mitral stenosis. What will happen over time to this left atrium? Well, the increase in the residual blood that cannot enter the left ventricle will cause circumferential expansion of radial length of that left atrium. To compensate, the heart will increase the thickness of the myocardial wall and the ability to relax by adding sarcomeres in series. This eccentric hypertrophy of our left atrium will decrease the wall tension, but at the expense of possibly causing contractile dysfunction and overdilatation. Remember what we talked about? What structure can be compressed by an excessively dilated left atrium? The left recurrent laryngeal nerve. What are some other things that can happen when you stretch that left atrium too much? Well, when you stretch myocytes, you disrupt some of the cellular gap junctions. Remember, myocytes are connected by connexons. This is our connexon. So you can actually stretch these myocytes and disrupt these gap junctions. You can also disrupt the individual pumps on each myocyte that maintain ionic concentrations, and it can lead to atrial fibrillation, which is when the atria is constantly being depolarized by reentrant circuits. We will discuss this more in depth in the electrophysiology section. So if the atria is just quivering, because essentially it is doing little mini contractions because there's so many different little mini depolarizations instead of one big synchronized one, what is that blood going to do that is just chilling in the left atrium? Well, it's basically static. It can form a huge clot. This is super bad. And that is a huge association with pathology of a murmur that can cause excess blood to pool in that left atrium.